really enjoyable to be here, and everyone's been so friendly, and it's just really nice to have conversations. Leo, I saw the demo. You guys showed me a demo of the sixth digit or the second thumb, and that was really cool. And I saw David again, and Matteo. It's tough to follow Matteo's talk, I'll have to say, because it was so impressive. But yeah, so I'm really happy to be here. Thank you for coming. Thank you for your attention. As Rafa said, yeah, this is really getting fairly close to some of the stuff that Tamar and her team have been doing and have been leading, really. And yeah, so I'll just get started, and hopefully you find it enjoyable and useful. So I'll start by introducing the folks that make the work possible. And maybe I'll just say a little bit about kind of what we're doing, right? So we have patients come down and visit us at Bangor. They undergo some functional MRI scanning, and they do some behavioral tests. They're there with us for about 6 hours. It's a full day of experience. We break that up. We have a very long lunch, and it's not testing the whole time. And so they travel from around North Wales. That's made possible by our connections with Mr. Edwin Jasudison, who goes by Prash, a hand surgeon out of the local NHS trust. And then also through Professor Lees. Vivian Lees is a real powerhouse, not only a renowned surgeon, but also a powerhouse academic. She works out of Wythenshawe as part of the Manchester Foundation Hospitals Trust. And Wythenshawe is one of the largest nerve trauma centers in the UK. So the patients travel down, they come with us, they're with us for the testing. I have also expertise coming in from Francis and Andrew and my more senior colleague, Sai. So it's a big team, and as inherently multidisciplinary, you need to bring in clinicians and surgeons. I don't have there, and I should, Louise Booth, hand therapist locally, and Becca Henderson. It really coordinates a lot of the work out of Bangor as well. But the most important thing here is that the work I'm going to share with you is Martin Weber's. This is Martin Weber's, a big part of his dissertation as a doctoral student with me. And it's a relatively large group there, but on the ground it's really small. It's me and Martin, and so Martin's doing all the heavy lifting, and really he deserves full recognition, and I just want to make that very clear. I could have his image and his name on every slide. I didn't go there, but perhaps I should. So, and we've got support for this project from the Wellcome Trust as a seed award. So how does the brain change after hand nerve injury, and what do these changes mean for patient recovery? So we understand that if one of these injuries happens in adulthood, recovery is incomplete. I should say, I didn't actually specify the patients. These are folks that have suffered a traumatic laceration of either the ulnar or median nerve, undergone surgical repairs. And when that kind of thing happens, motor and sensory impairments and pain often persist indefinitely. Again, if it happens in adulthood. It's a different story if it happens in childhood, actually. So what role does the brain have to play here in recovery? Is recovery dependent on the capacity for the brain to change? Those are the big questions we'd like to ask and we'd like to address. To disappoint you on the third slide, I don't get there. We don't get there. And there may be too grand a questions at this point. But it's the dream. Instead, we ask a more specific, narrow question here. We do address them, and I think it is significant forward steps for us. We ask, is there changes in the brain of a particular kind? So we hone in on sensory cortex, primary sensory cortex, putative 3B, where we know there are preferential responses to particular digits, and we know that the organization of that has a spatial arrangement, right? So here's some of our data from a healthy control participant where the thumb is represented most laterally. See, and then you've got a continuum up through, a gradient up through to digit 5 more medially. So there's a spatial topography, as you all know. Those are the properties we're going to have a look at to ask the question, do they change after these kinds of injuries? So I'll now spend the time building up these two predictions. And first prediction is that the maps become less distinct. There's a blurring of the boundaries, if you like. The second prediction is that there's a change in the spatial arrangement, the topography. And so I want to spend a good chunk of time explaining why. What's the rationale for making those predictions? And I find it useful to do so. I find it useful to draw a distinction between two concepts. There are injury-driven changes in the brain and regeneration-driven changes in the brain. And I pluck this division directly from the literature. I'm borrowing this from a few experiments that have unpacked this a little bit for us, which I'll touch on briefly. The points I want to make, there's a couple of points I want to emphasize about this. The first is that there's been a lot more work on this bit, on the injury-driven changes, work that's been led by Tamar, and you know, these kinds of, about brain changes, you've got amputation, you've got spinal cord injury, you've got other deafferenting conditions where this kind of mechanisms would apply. Comparatively little has been done to understand brain changes after regeneration-driven. So by way of analogy, this is kind of like, you know, you've turned off the tap permanently. The lines of communication are broken and they're not repaired. This is, in the case of nerve injury and repair, you've restored the communication lines between the body and the brain. And you'll see that there is some evidence, mainly from animal literature, to suggest that there are brain changes, cortical changes, in particular in S1, that reflect this regenerative processes, these processes in the periphery. So it makes sense to make this distinction in the first place. So I'll spend only a little bit of time about the first bit because I think this is the more commonly understood part, right? So this is starting with animal research. This is an owl monkey. This is the typical canonical arrangement. After, in this case, this manipulation was an ablation, an amputation of digit 3. We see, I'm going to be a bit coarse in the description of these changes and just lean on this adjacent territory expansion idea. What's typically observed is that when recording from the cortical units, those units that were formerly devoted or preferentially responsive to, in this case, digit 3, come to take on responses of the neighboring territories, the neighboring digits. And that's seen with the loss of a whole hand in animals where you've got face or residual territory. So that's the picture from animal models, and we know, as I suggested, there's quite a bit of work now with amputation in humans looking at functional brain changes. Tamar and her group being the world champion of this really, especially when it comes to this very we're thinking about this digitopy, right? And this is an example. I'll take some liberties to gloss over details. Otherwise, we should just switch positions here, and I'll just jump to some of the take homes in the sense that this is inconsistent with this picture from animal literature, in that what's seen is a persistent structure, that even after years after the loss of a hand, they find that the digitopy, the structure, is maintained. And I just want to say that the story has supporting evidence from multiple sources. There's convergence here. This is a really nice review paper by Tamar and her colleague, which I find very helpful. I won't talk about the conceptual thesis put forward there, but I find it very useful, the homostatic homunculus. All I want to say here is that there's evidence, supporting evidence, intersecting here to suggest that it looks different in humans, that there is quite a bit of persistence in the functional structure of the digits, even after this is a spinal cord, but yeah, deafferenting conditions. Okay, so that's the summary. That's the snapshot of the first bit. What about regeneration-driven changes? So here we have to come back to the animal literature. And there's been a number of studies that have done these kinds of manipulations. So to be clear, they've transected, in this case, the median nerve and surgically repaired it. And what's quite powerful about these experiments is that they, in another condition, they can block the regeneration. And then you've got comparison where you can really disentangle injury-driven versus regeneration-driven. And of course, all the things I just said about what they see about injury-driven, they'll overlap with what I'm going to tell you about regeneration-driven in time. So that often the picture is a mixture of these kinds of changes. But what do you find? You find, again, I'm going to be a bit coarse about it, but you find a reorganized structure. So we can notice that the topography that emerges over time has a kind of patchwork character to it, that you've got, it differs dramatically from the arrangement in the healthy animal. And some of this hash stuff is from the dorsal side of the hand. So now there are some sites that take on responses to the dorsum of the hand. And what's unclear, but I'll just tell you about it, these bits of cortex here with the dotted bits, they're bits that take on responses to stimulation of multiple digits. So there's a loss of specificity or selectivity. There's two things. There's a change in the structure and there's a loss in specificity. And I'll just show you a little bit more about what that looks like. So this one is kind of emphasizing the loss of selectivity or specificity. The median nerve services digits 1 through 3 in the owl monkey. So this is the uninjured ulnar nerve territory. And there, when you describe cortical units, the response properties of cortical units in 3B, you see the typical single receptive field, continuous, in that the responses are a continuous patch of skin that it's devoted to, right? What emerges on the other side is discontinuous responsivity. So number 7 is an example of this, what they're calling multiple fields in this study. And just to note that these kinds of results that I'll show you, has come from multiple labs and multiple groups. So yeah, so you get this loss of selectivity. This by definition is a loss of selectivity in cortex, right? This is the same kind of thing, only to show two more things, that over time, the density of responses, cortical responses, increases. These are 3 different monkeys at different times since repair, post-repair. The multiple field phenomena is restricted to the injured median nerve territory, and the density of responses is really particularly increases in the distal ends, as you might expect, because I'll say a little bit more about this. After the repair process, the regeneration of the fibers, the sprouting, they migrate out into the tissue. I'll say a little bit more about that in a moment. One final bit of detail about, in this case, the reorganized topography, is that it's not as if it's chaos that emerges. It's that there's a new order that emerges. So as you walk your recording electrode through cortex, adjacent sites represent overlapping parts of the hand. So this is an example here. This is cortical site 1, where in every one of these examples you see these multiple fields represented. But the thing to note is that 1 and 2 have a shared receptive bit, a shared bit of the hand that they're responsive to. As you get further and more distant in cortex, that's not true. In other words, a new spatial arrangement has emerged. It's not as if it's complete chaos. So those are the details. What do we know about regeneration-driven brain changes in humans? Very little. That's really the message. There's been some work with these kinds of patients that have taken functional brain measurements. These are the ones that we are aware of. I don't want to devalue this work at all. That's not my message here, but rather just to point out that none of them have asked these questions about digitopy. Okay, and I could say a little bit more about indirect evidence for thinking this kind of thing could happen in humans. I'll keep that short. I'll just say that one of the important bits as I started to talk about this kind of sprouting, this kind of regeneration stuff, one of the important aspects here to really digest is that there's no guiding signal. The regeneration processes are not topographically guided. So in other words, the sprouting fibers will make contact with new receptor sites at different parts of the hand. The brain will have to learn a new mapping. And so there's this rewiring that occurs. In fact, it's much more complicated than that. They can actually contact different classes of receptors. So formerly being an S1A could actually switch after this. But I won't talk about that. I'll focus on topography and the spatial changes. So now we're back to this point here. And because, I'm almost there. So because it isn't in our interest to try to understand how any potential brain changes relate to function, we did levy a hypothesis here, a third hypothesis. However, we just don't have much to work with here. We really, there's not much to support for this. This is really just a visual aid to imagine that it could go this way, it could go the other way, though. What I'm depicting here is the idea that changes may limit recovery. And so the greater kind of organization, the poorer the function. That's one thing you might intuit. For example, maybe a loss in distinctness really is something that would limit some aspects of functional return. But it could go the other way, and we just don't have, that's kind of the point. We don't really understand yet. It could be that reorganizational changes actually promote recovery and relate to functional recovery. So I'll start by just saying, how do we assess functional recovery? This is, the left's your right side of this equation. We have to characterize functional brain responses, and we have to characterize hand function. And, we did a lot of tests. I'm just going to offer this one today. I'm just going to show you data from what's called the Rosen test. This is the most common clinical assessment measurement tool for assessing functional recovery after injury to either the median or ulnar nerve. It's a standardized assessment tool. It's a composite score. So as an experimentalist, I was initially like a little bit kind of, how do you tell what the score means? Because there are all these subtests. You go all the way from pretty low level, touch sensitivity, up to pretty high level stuff like haptic shape and texture identification. And then the Sullivan workboard stuff, right? That's pretty high level function. But I can see after doing this work that it has clear value. It's very sensitive to impairment, and it's been developed up to being standardized and having good retest reliability and all those nice features. So we've tested 20 patients at this point and 29 healthy controls. And I want to highlight that the nerve that's injured, we have 10 ulnar injuries, 2 complete median nerve injuries, and 3 partial median nerve injuries. So those injuries require surgical repair, but the cut is incomplete. And then finally, 5 individuals that have had both nerves severed and repaired. And then the other thing to highlight is that in terms of post-repair, we're talking about 8 months or so is the earliest, all the way out to past a decade. So we have a fairly wide range of times since repair, and that's been known to be important for recovery. Just to give you a bit of a benchmark, it's about 18 months is the thinking how long it takes for motor regeneration to complete, and anywhere from 2 to 5 years, so that's right here, for sensory regeneration to complete. So we've got a real heterogeneous group. And so what do we do to characterize brain responses? Yeah, so most of them are below, yeah, near wrist, so lower arm. A couple of ulnar injuries are up high, actually. Yeah. So in the scanner, what are we doing? So we have participants lie in our 3T scanner at Bangor. We deliver vibrotactile stimulation to the digits. We test a single hand at a time. So we have these little epochs or blocks of stimulation where it goes on, off, buzzing at the fingers. That happens for each finger 7 times in a given run. So they're nice short runs. There's interspersed fixation periods. We adopted this paradigm after a paradigm by Berlot and Diedrichsen that also used vibrotactile stimulation. And we do both hands separately, so we give them a break. We do 5 of these runs, then they come out, and then they do the other hand. I just really wanted to orient you before going into the quantitative results. How do we quantify these maps, the characteristics of these maps? I just wanted to kind of show you an example of this. You saw, I think it was just this slice. So this is this individual. So to be clear, you know, these are 5 different contrasts. These are the thumb versus rest, and all the rest, right? So each one is versus rest. And yeah, you get this kind of, we're able to see this kind of predicted spatial order. It doesn't look this nice in every individual. I'm not going to, pretend that it does. But I hope this will allow you to better, follow me with the different things that we've done. We've done a univariate analysis and then a multivariate analysis, and they're really quite similar in terms of their, if you sort of understand this, you'll understand the other one, I think. So the first thing we do is we just, minimally threshold, and this kind of stuff, Tamar, you've kind of done some of this dice coefficient stuff before too, where you minimally threshold the maps. So this is classic univariate conventional contrast analysis. But all you're really doing is describing the extent of activation for the given maps and the extent to which they overlap. And if you put the overlap between 2 maps, for example, digit 1 and digit 2, and here we divide by the smaller of the 2 maps, you get a coefficient that really reflects the extent of overlap. So a value of 1 would be entirely overlapping, and 0 would be no overlap. And this is just a way to depict these kinds of data. And these are just made up numbers. This is just a theoretical set of predictions, and I'll just walk you through it. Along the diagonal, you've got D1 with D1, so there's no information there. There's really 10 squares of information, and they're redundant across the diagonal, so they're reflected. So the key bit is that as you walk away from the neighbors, you would expect less and less overlap. And this is predicted on the basis of the spatial arrangement. So on the basis of this understanding of how they're arranged, you would kind of predict that kind of pattern, right? So how do we test the 2 hypotheses? Well, this one's really quite simple. All we did was take the overall dice coefficient across all of these 10. Each one of these is a pairwise comparison of the overlap, a pairwise computation of the extent of overlap between the maps. And the prediction is just that the patients should have more overlap. If they've got less distinct, there's more overlap.
Okay, are you within 3B specifically, or are you taking the larger MRI?
So we hand draw the central sulcus in each participant and constrain the analysis that way at this point. We'd like to integrate surface-based methods as well. We just are stuck, technically, getting that to work. Just completely off. So are we in 3B? Yeah.
So it's just caudal to the central sulcus whatever activation.
Yeah, but we include the full central sulcus. So we're including the posterior and anterior bank.
But
So
are you going all the way to the post-central?
no.
So
Yeah. No gyrus, because these protocols, they activate premotor and all of that area at 1, and all the post-central, the crown. And so we really wanted to say, is it in central sulcus at least? But we're not disentangling the banks. Our resolution is 2 millimeter isovoxels. Pretty good, but I wouldn't want to leave stuff out. Yeah. So we have the caudal bank included. Yeah, so that's what, in a cartoon fashion, that's what the predictions would look like there. How do we evaluate this potential change in structure? We do a couple of things. I kind of already talked about this one already, right? That the fact that you predict the, where's the thing on this? You predict the neighbors to have more overlap. So if you just take the average of the neighbors, they should be higher than the non-neighbors. And this is just depicting that there might be a breakdown in that arrangement in patients. A little bit more nuanced is you take all the information, all 10 bits of information, you call that a pattern, and you use the controls data to specify the kind of mean estimate. This is the kind of canonical pattern that you'd expect. And then you evaluate patients one by one. Does a patient's pattern correlate with that mean from the controls? And you can get a controls estimate by using a leave one out kind of routine here. So that's this typicality score. That one's maybe more difficult to, are we good? Any questions? Cool. Okay, so these are the actual data averaged across the controls. So this is the kind of heat map stuff. I mean, you can see the lighter. I'll show you in a more quantitative fashion in a minute anyways. But this is the patients here. So in terms of just averaging across everything and looking at the overall DICE score, you can't get much more borderline than that. So if you, depending on what you want to do here, I personally am fairly happy to say that that's in the direction you'd predict. So this is the injured hand, but yeah, obviously right on the border there. So that's what that looks like. Here's a single patient. This one's a median nerve injury. A Rosen score, this is a pretty low Rosen score. A score of 1 is unimpaired. So you can see, I mean, it's hard to really evaluate this because there's a layering thing. I'm just showing you, really the only thing you could really pull out of here is just that the thumb seems to expand across the full thing. So you can kind of get a sense of the mask we're applying here in these images, right? That's it there, right? So, okay. What about the structure? So in terms of this neighborhood structure, this is kind of a busy graph, but this is the neighbor, non-neighbor, neighbor, non-neighbor. And then I like to subtract them, right? So if you subtract them and show them as a different score, you can also tell which of the points line up, right? So it's pretty consistent. There's only one control who doesn't show the predicted pattern here. And as a group, you're well above the 0, if that makes sense. And the patients are right alongside. I mean, no evidence for a change in structure at the neighborhood level, right? Yeah. When you evaluate the typicality, so this is, you can kind of think of this as taking into consideration all of the comparisons. There you do see a change, evidence for a change in the patients. That they are less typical than controls. What is surprising about this is that even the responses to the uninjured hand seem to have a kind of degradation in the typicality of the pattern. We can talk about that. And I'm really, open arms about any suggestions. We have some, obviously, post hoc interpretation, so we don't really know what to make of it. Absolutely nothing there with, one of the reasons why I said that the question is kind of beyond our reach is I think you could just say that with only 20 patients, you're really going to pull out a correlation, and I think you could argue that we need more. So, and they're pretty heterogeneous, but anyways, there it is. This is the Rosen score with overall DICE. This is the Rosen score with DICE typicality. There's absolutely no, even trend there. So can I just move along? I'll move along to the multivariate bits. So the key difference, I realize that you guys are all knowledgeable about this, but instead of just looking at the thresholded positive going bold responses, this is a method wherein you consider the negative going, and it's unthresholded. So everything else, I like to call it like the hills and the valleys. The former conventional thing is you're only looking at the hills. Looks at everything, the full pattern of responses. So you would have a kind of response pattern for D1 and D2, and you can ask, are they similar? Really what you're asking is, what's the dissimilarity between them by computing this Mahalanobis distance? And there we can fall back on other data. I just have the Berlot data here. It's limited in number of participants, but this really did use a vibrotactile stimulation. You know, a pattern that looks like this you could pull from some Tamar's work too, with a digit movement task. I think it looks quite similar, right? So you get this fallout, right? So where the neighbors are more similar with this metric. So yeah, I think you can intuit how we approach this. It's the same thing, except for, you know, the predictions flip, and that if you sum across the distances, you would expect them to be smaller for the patients, indicating a less distinct. And then finally, this is the same sort of thing, right? So if you look at the neighborhood structure, the neighbors should be smaller, closer together in distance space in controls. It offers a kind of benchmark too, right? A reality check to see whether the data conform to expectations. And then you can do the typicality thing in the same fashion, using all of the information here. So what did we find? Unlike the univariate approach, there's absolutely no evidence now for a change in the distinctness of the representations, right? And what else did we see? At the structure, the neighborhood structure level, very consistent with the univariate analysis. Here we get absolutely every control showing the pattern, and then the patients are really the same. So non-neighbors are further away in this space. The story with typicality is much the same as we saw with the univariate approach here, in that there's some evidence that there's a decline in the typicality for both sides. Again, not predicted with the uninjured sign. The story when we do these simple correlations is that we don't find any evidence here. I'm not going to speculate about any of that stuff. And that's really, this is the last slide. So this is really, well, aside from the thanks slide. So we find some evidence that there's a change in the structure, in the functional structure. And there's just, we haven't got to anywhere in terms of understanding what it means for recovery at this point, which that's the goal. So I thank everyone. Yeah, that's all I have to say.
Thanks a lot.
Yeah.
So we have lots of time for questions.